Good afternoon, ladies and gentlemen. I'm Dr. Alan, your friendly geriatrician from Penang. Welcome to the special lecture V4 entitled Improving Functional Outcomes in Elderly with Chronic Lung Disease. Let us welcome Dr. P. Srinivas. Dr. P. Srinivas is currently the consultant geriatrician and chest physician at Glen Eagles Medical Center, Penang. He was previously the Associate Professor of Medicine at the University of Malaya. He was the immediate past Vice President of Gerontological Association of Malaysia, a life member of the Malaysian Society of Geriatric Medicine, ex-member Care of Elderly Committee of the MMA, ex-advisor to Alzheimer's Disease Support Group in Penang, and ex-advisor of Penang Senior Citizens Association. He has special interest in geriatric assessment, stroke rehabilitation, management of dementia, prevention of falls in older persons, and COPD. Let us all welcome Dr. P. Srinivas.
Good afternoon, ladies and gentlemen. At the outset, I would like to thank the organizers of the Malaysian Hybrid Conference on Healthy Aging for inviting me to talk at this important conference. Thank you, Dr. Allen, for chairing this session. Today, I will be talking on improving functional outcomes in patients with chronic lung disease. Now, chronic lung disease or chronic respiratory diseases are diseases of the airways and other structures of the lung. Some of the most common are chronic obstructive pulmonary disease or COPD, asthma, occupational lung disease, and pulmonary hypertension as defined by WHO. But because of the shortage of time, I will only be concentrating on obstructive pulmonary disease or COPD for this talk. Now, the definition of COPD is it is a disease state that's characterized by airflow limitation that's not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. The components of COPD that contribute to the obstruction or airflow limitation, the most common is, of course, chronic bronchitis that all of us know, where the patient presents with a chronic cough and recurrent increases in bronchial secretion sufficient to cause expectoration. And this is present for about 3 months a year for at least 2 consecutive years. Chronic bronchiolitis is when the inflammation is more in the smaller airways, where the bronchioles are less than 3 millimeter, and this may precede and occur relatively early before the chronic bronchitic stage. Unfortunately, some people progress and are undertreated. They go on to develop emphysema, where there is permanent destructive enlargement of the air spaces distal to the terminal bronchiole without fibrosis. When all segments are involved, it's called panasthenia. But if it's restricted to certain portions, like the acinus or the terminal bronchiole, we call it centriasthenia. Now, COPD or chronic obstructive airway is a hidden disability in the aged. It's a major problem of old age, producing morbidity, disability, and mortality, and second only to musculoskeletal diseases in causing these problems in the old age. Most COPD sufferers will not present to medical care until the 60th decade, and the majority are over 65 years of age. Elderly people with moderate or even severe respiratory disease and impairment may not appear to be disabled. There is no badge of disability like a walking aid or hemiparesis, but simple activities of life like bathing or washing up may take up to 1 hour. So the major therapeutic goal in the whole ambit of my talk is how are we going to prevent the deterioration of lung function parameters and the reduction of the disability in this age group so that we can improve the health related quality of life in the elderly. Now, unfortunately, COPD, like hypertension or diabetes, is underdiagnosed and undertreated. Reversible airways obstruction has been estimated to affect 41% of elderly persons in nursing homes. Other research in Manchester has shown that 30%, one third of over 65, have airways obstruction, nearly all symptomatic, and despite showing a reversible component, most were underdiagnosed and undertreated. Elderly have a marked impaired appreciation of symptoms associated with acute bronchoconstriction, and hence symptoms like cough, wheeze, and shortness of breath have very low specificity in elderly people, and they do not come and complain to us about it. Lung function measurements with spirometry probably is so invaluable, and the only way sometimes we are going to diagnose airway obstruction in this age group. What is the scale of the problem worldwide? It's the fourth leading cause of death worldwide. In the Asia Pacific region, the prevalence is about 6%. And in Malaysia, if you look at the smoking prevalence, 47% in males, that's pretty high. And about 3% in females, and this continues to rise year by year. Only 15% of smokers will develop clinically significant disease. 80 to 90% of COPD cases can be attributed to smoking more than 20-pack years. Increasing tobacco consumption worldwide, increasing prevalence of COPD are going hand in hand, and this is putting a major burden on healthcare system. In Malaysia, in 2010, our MMR study showed that COPD was the seventh most common cause of premature deaths. The prevalence of COPD in Malaysia is 4.7% of the population of 32 million. That roughly about 500,000 people in the whole of Malaysia suffer from COPD. And if you look at the disability adjusted life years of the population, it accumulates to about 7%. Now, just in comparison with the USA figures, the real life registry there, COPD, the mean age presentation was 67, and a research of about 17,000 over correspondence, 56% were female. Unfortunately, 69% were in this obese, overweight category, 37% current smokers, and 42% ex-smokers. And about a quarter of them were not on correct maintenance medicines and still continued to smoke. Female sex was associated with a lower quality of life and a greater respiratory morbidity than males when followed up for about 3 years. Now, the next batch of my slides, I'll have to refer to the Global Initiative for Chronic Obstructive Lung Disease. This is the gold guidelines which all of us have to follow because they are evidence-based, they are changed every year, updated every year. And one of the main indicators they have made for the diagnosis of COPD is the first three, that is dyspnea, chronic cough, and sputum. Now, if you have a dyspnea that's progressive with time, worse with exercise, associated with a cough that may be intermittent or unproductive, with persistence, any type of sputum production, we are already thinking about a diagnosis of COPD. And at the background, if you've got a history of risk factors like tobacco smoking or smoke from biomass fuels, home cooking, or very, very important not to forget is ask the person's occupation. Occupational dust, fumes, gases, or other chemicals may also be implicated. And of course, always look at the family history. Now, the diagnosis is by spirometry, and on the left-hand side, you can see a normal spirometry trace, and here you have an FEV1 of 4 liters with a vital capacity 5 liters. This normal gentleman has a ratio of 0.8, which is perfectly normal. However, in a person with COPD, the FEV1 is markedly reduced to 1.8 liters, and the vital capacity is also reduced at 3.2 liters. So the ratio is only 0.56. That confirms the diagnosis of an obstructive airway disease. So immediately we could classify, depending on the airflow limitation, for all patients who have a ratio of 0.7 and they are given a PROS bronchodilator challenge. And if the FEV1 is above 80%, straight away we could make the diagnosis that this is mild, cold stage 1, but if it is 50 to 80, stage 2, 30 to 50, cold stage 3, and if it is less than 30%, that will be cold 4. So this is very, very important that we classify the stage, because for treatment purposes, this is the only way to go. The other two measures that we use is the MRSC dyspnea scale, where it's graded from 0 to 4. 0, the patient says, oh, I only get breathless with strenuous exercise. In grade 1, it's only on dyspnea on hurrying. Grade 2, I walk slower than most people, but I have to stop when walking. Grade 3, 100 meters, he has to stop. It's very breathless. But this is on level ground. And grade 4 is I'm too breathless to even leave the house, or I'm breathless even while putting on a dress or undressing. Similarly, we have the COPD assessment test or CAT assessment from the Jones group in the St. George's Hospital. They have got this 8 questionnaire scoring the maximum of 5 points if it's very bad. That means if you cough all the time, that is 5 points, and the degree. And similarly, coughing, do you have phlegm? Do you find tightness of the chest? There's limitation of activities. Is he confident on leaving home? Does he sleep soundly at night? And does he have loss? So immediately a person makes a score, and a score of more than 10 over these 8 questions straight away indicates that there may be issues on severity of COPD. Now, using all these tools, using the spirometry, using the assessment of symptom risk, and then trying to use a post-bronchodilator response, then we are able to classify into the different goal stages, and then also looking at the exacerbation histories, we are able to classify into that ABCD classification, which I'll come to a little later for treatment. So also, before making a final diagnosis, make sure you rule out other conditions like asthma, congestive cardiac failure, bronchiectasis, TB, or any form of an obliterative or pan-bronchiolitis. And all these have their own features, own investigations, which I will not go into in too much detail. So the final goal of our assessment and management from now on will be to relieve symptoms, which is basically the dyspnea, improve exercise tolerance, improve health status. So by doing that, you already reduced the symptoms. The patient feels better. But we need to do a bit more further by preventing disease progression. How are we going to prevent and treat exacerbations? And how are we going to reduce mortality? So all this will also reduce the risk. So that will be our goals that I will talk about in the next couple of minutes. So the first step is the pharmacological treatment. We are now classified into A. The A group, as I has told you, is a mild group where the MRC classification is less than 1, maximum 1, CAT levels less than 10. From B, it starts increasing. MRC is more than 2, the CAT levels are more than 10. So starting from a normal, simple bronchodilator, they progress on to a long-acting This is a short acting, maybe then we progress on to a long acting beta agonist or a long acting muscarinic agent. But most of our patients unfortunately are not diagnosed in the A and B group. They come at the group C, where they've already had 1 or 2 hospitalizations and they are already in an MRC of 5 and a CAT of 15. Now, these patients straight away are started on long-acting muscarinic agents. And finally, the group D, where you may need to combine a long-acting muscarinic agent with a long-acting beta agonist, and sometimes use the corticosteroids also, for which there are particular rules for us. So this is an extremely busy side, but we have a huge number of medications that can be used, as I've told you, starting from the short-acting beta agonist, the long-acting beta agonist, the short-acting muscarinic agents, then the long-acting LAMAs. This is really the foundation for most of our patients, LAMAs. Then we have the combinations, where we have a PRN use, where you have a short-acting beta agonist plus anticholinergic and various methods, even nebulizer usage along with inhaler time. But now, one of the most commonly used are the combination of a LAMA-LABA combination. These 5 medications, either in a soft mist inhaler, dry powder, or a metered dose inhalers, have been introduced. And last but not least, a triple combination therapy has also come into play in the management of COPD. So basically, let me reiterate that the bronchodilators will be and will remain central to the symptom management and are commonly given on a regular basis to reduce symptoms. The evidence is very high at level A. Regular and as needed will improve the FEV1, level A. Combinations are superior compared to medications alone. So either SAMA or SABA is rarely used now. So combinations definitely improve the FEV1. And then if you combine a LABA and a LAMA, you are going to improve lung function further, improve dyspnea health status, and reduce exacerbation rates. LAMAs, remember, have a greater effect on exacerbation reduction compared to LABAs. And there's a lot of randomized controlled trials, which are many to mention. And that's why they've gained the level evidence A, and some other trials that they even reduce hospitalization at evidence B. Combination treatment with a LABA and a LAMA increases FEV1 and reduces the symptoms compared to monotherapy. And finally, the combination is definitely reducing the exacerbations compared to monotherapy. Now, if a LAMA that was initially started the treatment of COPD, which is called tiotropium, has very good effects in the effectiveness of pulmonary rehab. A combination of this was also tested in trials, gaining a level of evidence B. Last but not least is theophylline, small bronchodilator effect in stable COPD, evidence A, and this is having good symptomatic benefits. So these are some LAMA-LABAs which I mentioned. The initial one that started the ball rolling was tiotropium or Spiriva, initially a dry powder, but now we have a soft mist inhalers, which also progressed on to a combination of tiotropium and albuterol, also in a soft mist. These are extremely useful in patients who have a low expiratory volume rate. That means their inspiratory flow rate is very poor, very elderly people who cannot take a deep breath and keep a breath hold. So this has found to be extremely useful and very effective in these sort of people. For those who have a better inspiratory flow rate, maybe a combination of LAMA-LABA like Anoro in an ellipta device or a pre-inhaler like Ultibro, where it's a combination of indacaterol and glycopyridine. So these are the common combination and a single agent which are commonly used for COPD pharmacotherapy. Now, when do we introduce corticosteroids, inhaled corticosteroids? Now, there is very strong support if patient has been hospitalized, more than 2 attacks. But the most important thing, 2 things will be the blood eosinophil level should be more than 300, and there must be a concomitant history of asthma for a long time, and he has progressed through an overlap syndrome into COPD. But definitely, we cannot use it for patients who have recurrent bacterial pneumonia. It's not advised. With eosinophil counts of less than 100 and who have either mycobacterial or non-tuberculous mycobacterial infection, especially people who have COPD and bronchiectasis, that combination to use ICS along with the LABA-LAMA is not recommended. So another important tool that we have that will help people with COPD is oxygen therapy, and we know that we give it for patients who have an arterial hypoxemia with a PO2 of less than 55 with a saturation of less than 88%. Remember that, all right? And of course, in patients who are already developed pulmonary hypertension, right heart failure, you can still use it. It is very useful. And prescribe supplemental oxygen for more than 12 to 16 hours a day. And after 3 months, assess whether they have improved, how is the saturation, and then we can titrate it accordingly. Now, this is the oxygen concentrator, which is portable. In the house, can be moved around with wheels. And this is, of course, the more expensive, which can be carried in the car and onto the golf course and etc., etc. Now, last but not least, we have to think about patients who are extremely in an advanced COPD. That means they have significant emphysema type of phenotype. They have severe inflammation. They have large bullae. If the bullae are extremely large, they may be considered for what we call as a bullectomy surgery. Now, then we have 2 groups of emphysema, whether they are heterogeneous or homogeneous, whether they are bulla or not. Now, these people have no large bulla. They can be classified again, those which having collateral ventilation. That means they have good blood. They have not good blood supply, which is supplying all the lobes. For collateral ventilation, and those again in the homogeneous, the same division. Now, as you can see, this will be more explained in the next slide, but this LVRS stands for lung volume reduction surgery. BLVR is what we call as bronchoscopic lung volume surgery. EBV is endobronchial valves. Now, endobronchial valves, as you can see, are inserted in patients who have a definite fissure and you're sure that there's no extra blood supply coming to the lobe. And you insert your valve, block off that lobe, and you ablate, sort of an ablate, you collapse that lobe. But if the patient has got an incomplete fissure, there is blood flow from the middle lobe, for example, coming up to the right upper lobe, then valves cannot be used. So then we need to use what we call as lung volume reduction coils or vapor ablation treatment. So this is the example of coils, and this is the example of valves that can be inserted, both this is a coil that has been inserted through bronchoscopic techniques. And of course, even the bronchoscopic thermal vapor ablation has been done in Sudan, and this has been used to ablate a portion which has an incomplete fissure and there is collateral circulation. We have no choice but to use this method also. These are some tools. So basically, to summarize, lung volume reduction surgery improves survival. In severe emphysema, especially those who have upper lobe emphysema and who have low post-rehabilitation exercise capacity, the evidence is at a level A. So definitely it needs to be considered. Now, bulectomy, the level is C, but sometimes with very large bullae that are restricted to the right upper lobe, the cardiothoracic surgeon may make a decision that it's quite safe to remove that bulla. Transplantation is only in very appropriately selected patients with very severe COPD has been shown to improve the quality of life and functional capacity. Bronchoscopic interventions have become the way to go because it's non-invasive. Select patients, it can beautifully reduce the end expiratory volumes and improve the tolerance, health status, and lung function. And the level for endobronchial valves, which have been used for more than 10 years, is at the evidence of A. Coils, evidence B, and vapor ablation, which I've just told you, which was done, is evidence B. So we have various techniques that we are using now for patients with advanced emphysema who can benefit from lung volume reduction. So the key points of to summarize again is education, 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 so that there is a way we can manage this patient by a care plan. All right. And remember not to forget that rehabilitation is indicated in all patients with relevant symptoms, and the evidence is A. So I'm going to talk on the next half of my talk, concentrating on pulmonary rehab. Nutrition is important, and of course, in some patients who are really bedbound with severe emphysema, we need to also not forget about palliation and end-of-life care. Now, regarding vaccination, I put another slide. It's much easier. Influenza, many talks are going on about this. Definitely reducing illness and death. All COPD patients must get a yearly vaccination. For SARS-CoV-2, recommendation is quite strong. Now, the pneumococcal vaccine has been shown at the evidence of B in patients age 65 years and less with FEV1 of less than 40%, and in those with some comorbidities. In general population of adults more than 65, the 13-valent conjugated pneumococcal vaccine has demonstrated significant efficacy in reducing bacteremia and serious invasive pneumococcal disease. The CDC, not to forget, recommends even tetanus vaccination to protect against whooping cough, or especially patients with COPD who are not vaccinated in adolescents. And also herpes zoster vaccine has been recommended in this elderly age group. So now coming to our final portion where we need to look at pulmonary rehab in much more detail, because pulmonary rehab is the way to go in majority of the patients because it improves health status, dyspnea, exercise tolerance, and it reduces the hospitalization among patients who have had a recent exacerbation. Okay, and it leads to a reduction in the symptoms of anxiety and depression. So let us define rehab first. Now, pulmonary rehab has been defined by the ERS and ATS as an evidence-based, multidisciplinary, comprehensive intervention for patients with chronic respiratory disease who are symptomatic and have often decreased daily activities of living. It is designed to reduce symptoms, optimize your functional status, increase participation in society and the day-to-day life, that social life that one wants to live, and reduce the healthcare costs through stabilizing and reversing the systemic manifestations of the disease. So what's the rationale? Now, we know that patients with severe COPD are becoming progressively less mobile. They are reducing their ADLs. The muscle wasting is a common finding and has a negative impact on survival. Gains in body weight, muscle mass, strength will automatically be associated with better exercise, tolerance, and a longer survival. Consequently, improving peripheral muscle function is an important therapeutic target in patients with COPD. Physical activity is the strongest predictor for an all-cause mortality in COPD. And when you have increased activity, you have better prognosis, better cognition, better survival. So rehab has no doubt about it. It has a beneficial effect on all the symptoms and the health-related quality of life in stable COPD patient. A multidisciplinary approach of rehab can improve the peripheral and respiratory muscle, and combined with nutrition and ADL training, they will really improve the quality of life. Now, just a quick look at the comparison. If you can see a healthy individual, the daily activity pattern, 41% is standing, 42% will be sitting, and walking about 11%. So more than half the time he's on the move. Sitting will be less. All right. But if you look at the COPD patient, there is a lot of inactivity. He is lying 12% of the time and sitting most of the time. Almost 62% is on the sitting. Walking is only 6% because he gets breathless. He stops. He cannot walk any further. So basically, the exacerbations of COPD, the tachypnea, the anxiety, the deconditioning, all tend to cascade into what we call a poor health-related quality of life. Now, the peripheral muscle weakness is quite significant, as you can see in comparison with the shaded, which is normal, in the quads, pectoralis major, or the latissimus dorsi, all there's a 20% better strength compared to somebody with COPD. There is definite peripheral muscle weakness. And we look at the VO max, which is the volume of oxygen that's consumed when somebody exercises. If you are at the gold stage 1, you consume more than 1,995 milliliter, compared to a peak volume oxygen consumption of somebody with only 654 mils, because it's so distinct. The oxygen consumption is so poor. And look at the month of follow-up in this paper in 2003, over a 60-month follow-up, the rapid decline in the portion of surviving. Those with 1 and 2, almost 90% are still alive. But if you look at gold class 4, you find only 40% survival. So basically, the VO max or exercise capacity can be a predictor of mortality in a lot of older people with COPD. So we need a multidisciplinary team participating in pulmonary rehab, comprising of physicians, therapists, whether they are PTs, OTs, or respiratory therapists, nurses, nutritionists, social workers, and probably sometimes a psychological assessment and management of anxiety may be required. And the components may be always to educate, evaluate, look at medicine usage so that we can prevent the exacerbations. Make sure that chest physiotherapy is started at an early stage, functional ADL, IADL assessment, retraining after a discharge, upper, lower extremity exercises, muscle retraining, reconditioning, and a complete psychosocial assessment and stress management. Because we know from the many studies that depression and anxiety are major components of patients who are having COPD. So we need to look into this and assess the psychosocial factors. And last but not least, sarcopenia is a major problem, frailty. So nutritional assessment and advice also should go hand in hand in pulmonary rehab. So as I've already told you, education. Now in rehab, you can divide it into aerobic exercises, which may be just walking, maybe slow jogging, maybe swimming in some people, just a couple of sessions a week, maybe 30 minutes, and look at the fatigue setting in and stop. Muscle training, which must be important, a resistant training with a reduced load. Look at the target muscle groups, the quads, the pecs, which needs to be improved. Balance training may be very, very important in some people. And last but not least, to look into the breathing exercise. First, must be a forced expiratory technique which can expel the sputum, and second, a positive expiratory pressure to assist the forced expiration. And of course, the OTs are very good in assessing and providing the ADL, whether it's basic or instrumental. This also should be looked into whether help is required in this field. So going back to the breathing exercises, I reiterate simple exercises like the pursed lip breathing. Relaxing, take a deep breath, 2 seconds through your nose, keep the mouth closed, and then with the pursed lip, blow out for about 4 seconds or twice as long as you can breathe. And this pursed lip breathing is combined with what we call, with diaphragmatic breathing, where the muscles are tensed, one hand on the abdomen, inhale through the nose, tighten the abdominal muscles and keeping the chest muscles still, and then you slowly blow out. So these exercises are very important, and to expel the sputum in many people with chronic bronchitis, the huffing cough technique, upright, 3 deep breaths, bending the arms, raising the elbows, holding the breath, and using a forced expiratory technique, which is called as huff coughing, can consist maybe 1 or 2 coughs, and a mid-lung volume, the glottis is open, and that will exhale forcefully and clear the phlegm. So these are some of the important techniques that are put into place. We do not want, of course, our patients to end up in such a ill condition where they are fatigued, where they are always coming in with respiratory infections, using muscles of respiratory, dragging themselves along. We did not want this situation to happen. We rather see our COPD patients like this elderly couple. They have a plan of action for life. They are living well with COPD. And as the Canadians say, row your own boat. Educate, empower the patients and the family and the relatives that COPD is not an end and all. By using smoking cessation, promoting a healthy lifestyle, by regular exercise, nutrition, and management of the exacerbations properly, we can give them a good quality of life. So remember, summarize again that pulmonary rehab is a real cornerstone that we cannot do without. It's not medications alone. We need to put the pulmonary rehab component very strongly to improve the functional capacity. And look at all the first 5, all at a level A, increasing exercise capacity. It reduces the dyspnea, improves the quality of life, reduces hospitalization, reduces anxiety and depression. So your team can achieve all this. And of course, not too bad in improving arm function or survival at a level of B. And of course, for improving respiratory muscles and psychosocial interventions have also gained evidence of grade C. So there is numerous benefits of pulmonary rehab that should be instituted. Now, before I end my talk, I'd like to just bring to your attention Mr. Russ Winwood, who was actually named the COPD Athlete of the Year for 2017. He is suffering from COPD for more than 20 years, but by good management, he was able to run the London Marathon in 2017, and he has got a medal as a finisher in 5 hours 22 minutes. And this is a quote that he said, that on 23rd April was his birthday, but it was also the day he ran the London Marathon with other COPD patients. But it has started long ago that a lot of COPD patients have completed, like Stephen Goddard, McBride in 2009, veteran marathoners. So these are all legends. They have inspired a large number of respiratory patients to take on the endurance challenges and show the world that you should never be defined by your disease, that you can do it. You can manage COPD in such a way that you can achieve the goals that you have set in life. So let me end by quickly summarizing what I've said so far. We have talked about diagnosing a COPD through the symptoms, risk factors, and a spirometry. Make an initial assessment using the CAT and the MRC scores at the level that the patients need to be treated, looking at the smoking status. And if it's a very young emphysematous patient, don't forget the alpha antitrypsin check. Look at the comorbidities and make sure they are managed well, whether they have hypertension or diabetes. And after the initial management, which may be pharmacotherapy and a risk factor assessment, inhaler technique, breathless action plan, we can adjust it accordingly, whether it's pharmacological or pulmonary rehab, to achieve the goals that we have need to, basically to reduce the risk of further exacerbation, improve the quality of life, and improve dyspnea in these patients. So let me conclude by saying that multidisciplinary and a multidimensional approach can definitely improve the functional outcomes in elderly with COPD. And I thank you all for listening to my talk. And then I'll hand you over to Dr. Ellen to chair the meeting. Thank you.
Thank you, Dr. Srinivas, for the very comprehensive coverage of COPD in older person. So now we are open for questions from the virtual participants and also physical. Yeah, virtual participants, you may type into the chat box. Yep. Nope. Okay. Just now you quoted around 20% of those diagnosed with COPD and still continued smoking. So, what's your thoughts about that, Prof? Okay. And what can we do about it, actually? Can you hear? Okay. Just now in your talk, you quoted the number of 20% of those diagnosed with COPD who still continued smoking. What's your thoughts about that?
Thank you, Dr. Allen. I think it's the burden lies on all the public to get involved in educating people about how we can address to stop smoking in this group of 20% or so, because I think the government is doing its share in trying to show the dangers of smoking, but I think it's not only doctors, the GPs, the hospital doctors, but every public should in some way or the other influence by educating people the dangers of smoking. especially in the younger age group. I think we should start educating from our primary, secondary, and into the university levels, because a lot of the smokers start young at the age of 15 and below that, and that is the time in the primary and the secondary age group we can inculcate into our young children and adolescents the dangers of smoking. And I think by constant education is the only way that we can overcome this difficult problem of people at the age of 18 already smoking one packet a day. And then it's very difficult to give up smoking, as you know, that people who are already addicted to smoking, they find it extremely difficult to, and that's why we have clinics now in most of the government hospitals to assist smokers to give up. Most of the chest clinics do have some form of a quick smoking, but it's very difficult still that people do go back to smoking. So I think we need to address this group of persons who continue to smoke, who at the age of 45, 50 will end up with chronic lung disease. And then by the time they retire, they are already disabled.
Previously, one of the consultants that I worked with, he said this, all patients with COPD have coronary artery disease until proven otherwise. We have Dr. Wong here, our cardiologist. Do you agree? Oh, cannot hear. Again, Dr. Srinivas, can you hear me? Hello?
Yeah, can I add, Dr. Allen, about coronary artery disease? Yes, definitely. There are a lot of comorbidities in patients with COPD. And of course, majority of them unfortunately develop, some form of right heart failure also. So there may be double whammy for many of them, that they also develop hypertension because of the smoking, diabetes. There are a lot of other comorbidities, and cardiac-wise, they may have underlying. I do not know the figures. The cardiologist may help me on that. But of course, they often develop rising PCO2s and right heart failure. So if they have underlying coronary artery disease and their right heart failure, it's global hypokinesia soon. So it is definitely a double whammy for these people. Yeah.
Any questions on the floor? Okay. Another common phenomenon is the very high hematocrit in COPD patients with smoking, chronic smokers. So, would you consider venesection for this type of people?
Yes, I think polycythemia is some people, is a way of diagnosing heavy smokers. Yeah, we are always taught that watch out for polycythemia and ask about smoking history. Very good point, Dr. Allen. And of course, we need to decide on the hematocrit, the polycythemia, and whether it's causing any side effects like, we look at the fundus, we look at whether he's getting severe headaches, and often we ask the hematologist whether it will help. They look at the blood film, and then finally it's the hematologist really will decide on whether they need, of course, any levels that are extremely high, they do suggest venesection. and that helps, but temporarily. But the way to go is stop smoking, which is sometimes a difficult task, but definitely many of them will benefit from venesection because they come in with headaches and giddiness, and they definitely do well after venesection. I've referred a couple of cases to the hematologist, but they take the final decision when to venesect.
Okay. Any questions from the virtual participants? No. Any last questions? No. So I think there's no further questions. Thank you very much, Dr. Srinivas.
Thank you for your, Dr. Alan.
Yeah.
Thank you all.